You know, Mike, you're one of the few folks I know that really plays in both the venous and arterial space. As it turns out, there are a lot of shared risk factors. Inflammation is one that's particularly hot. What are your thoughts on just sort of the overlap of risk factors for venous thromboembolic disease and arterial syndromes, things like MI and ischemic stroke, for example?
Well, you know, it's interesting. We tend to study these drugs in people who are medically or venous patients or arterial patients, but patients have both arteries and veins, and they're at risk of events in both systems. So you're exactly right, Deepak. I mean, if you're at risk of venous thrombosis, you're probably also someone who, in terms of having bad blood, is also at risk of an arterial thrombosis. And when we talk about the treatment here, we're going to see that, yeah, we reduce the venous events, but we also reduce some of the arterial events, things like stroke and heart attack. The people in the hospital often have something like a stroke, which puts them at risk of immobility, or there's someone who had a heart attack who then went on to have heart failure. So these two systems are just highly, highly interrelated.
And you know, you mentioned bad blood. Dr. Fuster used to talk about this concept of vulnerable blood. Do you think there's something to that?
Absolutely. And you know, every meeting we come and we find out another biomarker of thrombogenicity in bad blood, and we not only have to treat the risk factors in terms of immobility, but also the bad blood.
So, Gary, we've talked a bit about venous thromboembolism and medically ill patients that are heightened risk for VTE. How can we really gauge this risk? What should we be doing?
Well, I think the most important thing is that in a health system that there is a process for a routine assessment, risk assessment for VTE for every patient who's admitted to hospital. And there are evidence-based approaches to do that. There are apps that can be put on phone, or you can work with your IT department in the hospital, you can work with your patient safety and quality department in the hospital, but really in present day, every patient admitted to hospital should have a risk assessment for VTE.
And you think it's really something that should be happening at a systems level that is pre-programmed into electronic health records, or is it up to individual physicians to sort it out on their own?
No, I think clearly a lot of evidence indicates that you have a much better outcomes and results if you do this in a system level and implementation at a system level. After all, physicians have lots to think about and worry about, and I think that if these kind of things can be simply automated and made routine through these information technology systems and other approaches, that's the way to do it.
Yeah, Deepak, we've had good experience programming in things like CHADS-VASc to identify high-risk patients with AFib for stroke, and it's really the electronic health records now are so elegant in their constructs that we can actually pull this information fairly easy and take the duty off of the providers, like Gary said, and make it easy for them to find the right patients.
Well, you've done a lot of pioneering work in that regard, and certainly at the Brigham, you've been in charge of getting those systems in place. And I think Gary's right. I mean, the onus does fall on the healthcare system. As an individual physician, it's tough to keep track of all that stuff. I mean, there are all sorts of risk scores out there, right, for acute coronary syndromes, atrial fibrillation, PE, VTE, and for primary care physicians, you know, there's an even wider range. I just focused on some cardiovascular risk scores. So, you know, what would you actually do, Alex? What do you recommend in terms of risk scores? Which ones should we consider using, or should we just use our gestalt clinically? What's the right way?
I mean, I think, Deepak, you bring up an important point, and I agree completely with Gregory in the sense of, you know, scores like the CHADS or CHADS-VASc and other scores. What they do is they not only give you individual risk factors, but they weigh these risk factors and then assign a score to them, because not all of the risk factors are weighed the same. The nice thing now is that the business of risk scoring for VTE in this population is now gaining more and more sophistication, and we have a lot of background data to suggest there's a collection of very similar risk factors that put these patients at risk. You have the acute medical illness, you have the level of immobility, which are what I like to call disease-specific risk factors, but then you have the patient-related risk factors, and a lot of these risk factors are enduring. Risk factors such as advanced age, or prior history of VT, it's a very strong risk factor, or history of infection, or history of thrombophilia, or active cancer, history of cancer, or admission into the ICU. So these are all risk factors that are, again, dependent on the patient or somewhat on the disease. The nice thing is whether you look at the Padua tool or the improved tool, and the reason why I shouted out these risk models, because they've really undergone the most external validation, both of these scores, is that they really align nicely with those kinds of key risk factors. And what they do is then they give the clinician a score, and depending on what threshold scores reach, they would assign patients into at-risk or even sometimes high VT risk categories. And I completely agree with Gary. The key is not so much what score you use. You should use a validated score, but the fact that it's systematized and universalized within a health system. That's what's critical.
Yeah, no, that's good to reduce variation in care. Yeah, Michael.
And if I could add, we now are just about to publish machine learning and artificial intelligence for VTE. Scores are great, and we worked on the improved score together, adding D-dimer into all those clinical assessments. But the advantage of machine learning and AI over numeric risk scores is it handles these kinds of things as a continuous variable. And instead of using 5 or 6 things, you can use 50 or 60 things from the electronic health record to have an even more precise estimate of risk. I think all this is too much for clinicians in many ways. You can't think about 50 things simultaneously. I can barely think about 2 things simultaneously. But this is where the electronic medical record is going to shine, is in the ability to pull all these factors together and then in an automated fashion give us these risk scores, which are better than the old 1, 2, 3, 4, 5 kind of risk scores.
And I'll just digress for a moment. Maybe you could just share with the audience, I know you're leading a lot of this type of machine learning work at BAME. What exactly does machine learning and AI in this context refer to? What's going on?
Yeah, that's a great question, Deepak. So you take a lot of information, you take all the data, for instance, from a trial, and then you figure out which ones of these variables are most related to the outcomes. And rather than looking at linear relationships in one dimension, it looks at curvilinear relationships in multiple dimensions. And it's a little bit more like a neuron firing. You put in information and you see, how do you weight the firing of all these different synapses to get the answer that fits truth? And then you tweak all those synapses. It's a little bit of a black box, but it does outperform traditional risk scores. It needs to be learning, so the answer today may not be the same as the answer in 2020 because all the systems of practice have changed. But again, as an adaptive system, it's able to better adapt to all the new information than we could as clinicians.
Yeah, no, that's really interesting.